The University of Michigan Division of Gastroenterology and the Inflammatory Bowel Disease Program host the IBD Visiting Professor Lecture Series in Ann Arbor, Michigan. This series presents the latest in clinical research and basic science from IBD experts from around the world.
It's a great invitation to come out here, and it certainly is a special place to come. And what I'm going to do is sort of review with you where a number of things stand more on the clinical side, and most of my research really has been on the clinical side, and tell you sort of where we are in the field and a couple of relatively important questions that we're seeking to answer. And when I say we, I mean the larger IBD community. We at Mount Sinai, only have what we've got. As you know, up top, we have sort of a very simplified diagram of what's often called the Vogelgram, named after Bert Vogelstein, Nobel Prize pending, to my mind. And it really sort of lays out the multiple hit hypothesis for the development of colon cancer. And it's for sporadic colorectal cancer up on the top frame there. And you can see that there are certain changes that happen in the pathway from normal mucosa to dysplasia to colorectal cancer, with APC mutations or problems in the APC system happening early, and P53 being a late change on its development to carcinoma. And really by analogy, and this is really only a summary of some cross-sectional studies, quite sadly we've not been smart or clever enough to do any good longitudinal studies, and again the we is the larger world, myself included though. In colitis-associated colorectal cancer, we do start with slightly different mucosa, and we have this chronically inflamed mucosa, and it turns out that when studied, at least some problems in the chromosomal instability pathways happen earlier, such as the P53 mutation, and changes in the APC system happen to turn out to be very late events, but there is that intermediate of dysplastic tissue as well. It would be nice if this was always the pathway, and if what we could see with our naked eyes endoscopically was always manifested this way. But how to get from one box to the next along the way, and how much time one has before you change states is really is not well known, though there's been a lot of attention and energy played into that. So this is what it looks like from the endoscopist's point of view. You get the adenomas, the intermediary up top again with sporadic colorectal cancer before it evolves into a cancer. I don't know about the rest of you. Maybe it's my black cloud. I never get that polyp right down there at 5 o'clock unless I'm doing maximal torquing with the scope, and it very seldom has a nice pedunculated stalk there. Dysplasia and colitis is a little different, and there isn't always a polyp. It's seldom, if ever, really pedunculated. And I would suspect actually that image we have down there, the bottom middle image there, while we would all agree there's dysplasia there, I wouldn't rule out that there was a colorectal cancer lurking in there. And this is part of the challenge that we all face. And we'll get to the difference in the management of polyps and ulcerative colitis, and to some extent Crohn's colitis a little later on. But this is what we're trying to do. As you all well know, the development of colorectal cancer increases with increasing duration of disease. This is from a meta-analysis from Jane Eden done back in around 2000, published in 2001. And times have changed, and this is what it looked like back then. And we seem to think of this disease as sort of this great looking parabola, and that that with each advancing decade, the slope of that line was going to increase over time, and eventually we'd get to 100%. And it was always going to be a matter of when, not a matter of if you developed colorectal cancer in your ulcerative colitis. And this still sort of holds in the thinking, though I think there are data now to suggest that the shape of that curve has changed quite dramatically, and maybe these were overestimates. And I think part of the reason has to do with the advent of colonoscopic surveillance, which was not as big a part of things in some of the studies that Eden included in her meta-analysis. And so it's thought it would be about 0.5 to 1% per year after 10 years of disease. This meta-analysis, which is from the same Eden group, done by one of her colleagues, Canavan, is for Crohn's colitis. And actually, this is sort of an interesting story and speaks to the importance of good clinical epidemiology and really clear-headed thinking more than anything else. And so Crohn's disease was not always thought to be associated with colorectal cancer, and epidemiologically, it wasn't always associated with colorectal cancer. But it turns out if you subtract out your patients who've had a colectomy and you subtract out your patients who only have small bowel disease from the denominator, it turns out that you do have an increased risk, and that risk does certainly increase over time. But here you can see a difference in the trend here, where the points at least used in these estimates seem to line up and become a little more flat as opposed to that parabolic shape where it was pointing upwards toward 100% quite rapidly. So known factors to increase risk of colorectal cancer in IBD include duration of disease, as I mentioned. So we begin our surveillance at 8 or 10 years of disease. The extent of colitis, more extensive disease. Backwash ileitis, which is sort of an old-fashioned barium enema term. We tend to see some ileal inflammation when we have a gaping, wide-open ileocecal valve, and there's sort of reflux of the colonic contents into the TI. But backwash ileitis doesn't really constitute that colonoscopic finding, and there's been a mixed literature on whether or not it, in and of itself, independent of a full extent of disease, is a risk factor. Not surprisingly, a family history of colorectal cancer, independent of the IBD history, increases one's risk about 2 to 3 times. Primary sclerosing cholangitis, there was mixed literature early on. It's been very consistent since, and I think we all appreciate now that that's an independent risk factor. Early age of onset of colitis, in some studies has been an independent risk factor, not to mention that the lifetime risk becomes greater because of the early onset, but just that slope of curve is different and more impressive. And then something that a couple of groups, ours included, has demonstrated that histologic activity, the more inflammation you have, the more likely you are to develop dysplasia or cancer. In addition to pseudopolyps, there are other colonoscopic features that have been suggested. Activity at scope, although that's not been terrifically well appreciated, but actually entered into the British Society guidelines, and a shortened colon and a tubular colon have also been appreciated to be independent risk factors. Whether those are surrogates for bad inflammation at some point in time is anybody's guess. And similarly with pseudopolyps, is that because they're hiding the dysplastic polyps that we can't find, or rather is it just sort of a marker of a generalized greater inflammatory state and remodeling at some point that's given rise to the potential for the multiple hits that we saw in the Vogelgram? And I should mention, by the way, and I'm really sorry I didn't do this on that slide earlier, the bottom panel I'm trying to make the case is the Itzkowitz-gram, because my friend and colleague Steve Itzkowitz put that slide together and has been teaching all of us that that's what's important. And then finally, the one that matters to us most as clinical gastroenterologists is that dysplasia at surveillance is an independent risk factor for the subsequent development of colorectal cancer, and probably the one we care about most. We tend not to change things from moment to moment, year to year, based on these other factors. But if there's dysplasia at surveillance, we do things a little bit differently. Not all doom and gloom. There are some things that may decrease the risk of colorectal cancer. Not surprisingly, prophylactic colectomy. That's a hard sale to make to a patient, and in fact, I've talked to a few patients out of prophylactic colectomy who tended to be on the more fearful of cancer side of things. Regular doctor visits in a study by Jane Eden, and I don't think it's actually coming in and laying the hands on. I'm not sure what it is. And that seemed to be independent of medical therapy in her study, and whether more compliant or adherent to doctor recommendation patients or what she was really getting at with that, we just don't know. We've only seen that in one study. And then surveillance colonoscopy used to really be thought of mostly as a faith-based initiative. There hadn't been a lot of studies to demonstrate its utility. But with timely surgery and/or lesion removal and the addition of some adjunctive colonoscopic techniques, perhaps we're now at a point where there's at least one study that can demonstrate that that's helpful, and I'll show you that in a bit. And then we'll also discuss a little bit about chemoprevention. I'm certainly of the belief that we don't know whether the mesalamine-based agents are in fact chemopreventive, but there's certainly plenty of literature on that, and we can debate that till the cows come home. Ursodeoxycholic acid in PSC was initially demonstrated in both a case control study and a cohort study at lower doses, at least, to be chemopreventive. But for those of you up to date In the literature in the recent Red Journal, there was a study demonstrating that, in fact, it may be harmful and lead to greater risks of dysplasia and cancer at that 28 to 30 milligrams per kilogram per day dose. And it turns out that those patients are more likely to have problems in terms of their liver disease as well, more likely to die, more likely to need a transplant. So URSO's on the chopping block. Folic acid, thiopurines, these are still questions that are out there, unanswered, conflicting literature, or rather unimpressive literature, depending on how charitable you want to be to the authors of these studies. So we're going to review a bunch of issues, some of which I've already alluded to. And so the first thing that I did allude to and gave you, my take on the answer is the question of whether or not surveillance colonoscopy reduces the incidence of colorectal cancer in IBD-associated colitis. The paradigm for surveillance, and you can substitute in Barrett's, you can substitute in hepatocellular carcinoma in cirrhotics, you can substitute in a number of things, CAT scans for COPD patients. The notion is that after a certain amount of time, you initiate some form of screening and surveillance, that when you find your precancerous intermediary, you intervene and you interrupt the pathway along cancer and cancer-related morbidity and mortality in so doing. And that's what we're doing in IBD, and it's not clear that it's effective. And back when the Cochrane people reviewed this, and this slide really is much more a dig at the Cochrane people than anything else, right? Because we all work for them in clinical medicine, and what they say is the law. But here they actually they hedge. They hedge in a way I've never seen them hedge in anything else they've ever done. So you can see that there are really only 2 studies that met their criteria for entry into their analysis, and one of them, the Choi study, the one on top, is a terrifically flawed piece of clinical science. I don't think any of you guys related to Dr. Choi. I don't want to insult anyone unnecessarily. But they used surveillance detected cancers and compared them to survival in non-surveillance detected cancers, and that's really quite the no-no. So nevertheless, in spite of these 2 rather underwhelming studies and a point estimate that comes about as close to 1 with their forest plot as any forest plot diamond I've ever seen, yet they still say there's indirect evidence that surveillance is likely to be effective at reducing the risk of death from IBD-associated colorectal cancer, and indirect evidence that it may be acceptably cost-effective. And so this was one of those things where our technology outpaced our literature basis, but we still kind of thought we were doing the right thing, and even the Cochrane people had to sort of lay down and appreciate that was the finding. And so this is what came out in their 2008. There really are no randomized trials. I don't think there ever will be. I don't know of any patient, at least in the U.S., who would be willing to enroll him or herself in a randomization to surveillance versus no surveillance kind of study. And so we'll not get there. There have been 3 rather, scientifically weak cohort studies, one of which is positive, and then there's a lot of circumstantial evidence from case control studies, from decision analysis studies, and as I mentioned before, those faulty comparisons of surveillance detected versus symptomatic cancers. Symptomatic cancers always do worse by nature of what they are. Patients with symptoms at a given stage in any cancer will always do worse than asymptomatic patients at the same stage. So this is really the best of the case control studies. This is by Per Carlin and the group in Karolinska, and they took a look at Uppsala County, Sweden, and they had 40 patients with ulcerative colitis who died of colorectal cancer. They were able to match them to 102 living controls, and what they found, which was interesting, was that not only was there this element of protection with a single colonoscopy, albeit not a statistically significant one, and I apologize for no error bars on the right, but on the left you can see what the 95% confidence intervals were. But the point estimate moved down. It got smaller, implying greater protection at the 0.22 level for having 2 or more colonoscopies. And so there was this dose response to colonoscopies that was at least suggested by this non-statistically significant study, which was really hampered by only having 40 patients with cancer-related mortality. And so Jane Eden, and I think that this comes from the same study as her hands-on patient visit in APT in 2000, curiously found that while there were point estimates for 1 to 2 colonoscopies demonstrating efficacy, or effectiveness rather, in this case control study that actually more colonoscopies and your risk increased a little bit, which sort of doesn't make a huge amount of sense. And they defined surveillance quite well, and probably in reality it just has to do with the fact that, again, too small a study, bigger confidence intervals than we'd like to see. Barium enema, of course, found to be not useful at all. And then there was Fernando Valaios' study, which was based out of Olmsted County in Minnesota. And not only was there statistically significant protection with 1 to 2 colonoscopies, you had something of a dose-response curve with greater than 2 colonoscopies having even greater protection. So, it seems to be that now at least there's something of a literature basis that can help us out to say that what we're doing is effective. And I encourage all of you to continue to do your surveillance and not abandon it. And this is sort of one of those times when evidence-based medicine, while it can be helpful, actually can lag as well. And it's only as good as the clinical science that we toss into these models, and meta-analyses and Cochrane groups don't always solve all of our problems, not that we ever thought that they did. So another really important question that's out there that we've investigated somewhat is whether or not our anti-inflammatory medicines are sufficiently chemopreventive for colorectal cancer and morbidity in IBD. So Matt Rutter, who was at St. Mark's at the time and was there for a long time before he got, his family waylaid him and encouraged him to move to the north and east of England, and he lives up somewhere near the Scottish border now, and I only get to see him at meetings. Lovely guy. He did this very nice case control study using a 5-point scale of inflammation, and found out that while there wasn't an enormous difference in the inflammatory scores of patients who had gone on to develop cancer versus their matched controls, the odds ratio for each unit in their 5-point scale was actually pretty impressive. So 4.7 times risk, and it was statistically significant for each bump up in this 5-point scale of inflammation. They used a case control methodology. There was no adjustment for changes in dose over time, and the scoring system was novel for this and sort of hadn't really been tested to be accurate or reliable or reproducible. So we tried to take a look at this, and we tried to use something of a more rigorous, if we could, because otherwise we'd have never gotten published, something of a more rigorous methodology here. And so what we did here is we followed patients over time in a retrospective cohort, and we were able to make adjustments for inflammation for each patient with each colonoscopy that they had. We were able to look at inflammation in a number of different ways, and I'll show you our scoring system in a second, which is actually quite simple. And our endpoints were advanced neoplasia, either to high-grade dysplasia or cancer. We also took a look at any neoplasia where we threw low-grade dysplasia into the outcome of the model. Patients were followed until they either developed neoplasia or until they were censored for colectomy or the time of their last colonoscopy. And the adjustment that we were able to do with this time-changing covariate was in a proportional hazards model or a Cox regression. And as such, with each event, and this is the way these work statistically, with each event you recalculate scores for every patient who's still left in the analysis, again, until they drop out, until they're censoring or they hit their event. And this is the score that we used. And it's based on each individual biopsy or actually each jar of biopsies, Peter's favorite topic with me and my pathologist, having a histologic activity index developed. So each jar gets read out, as something like mildly active colitis or moderately active colitis. And we've been seeing this in our reports, and actually it turns out that our pathologists had a standardized way of doing this. And it's actually quite simple, so much so that I wonder why they get to charge all that they get to charge, because it's actually kind of easy. And they only have to count 2 things. One is whether or not there's an ulcer or erosion. And so if there is an ulcer or erosion, as you can see in the 3, which is our severely active, they're automatically severely active. So if you have an ulcer or erosion, you're severely active. If you have neutrophilic infiltration of your crypts, you are either mildly active or moderately active, depending on whether or not you have more than, and I can't remember what the threshold number of polys were per crypt, but if more than half of your crypts had met that threshold, you were moderately active, and if fewer than half developed it, you were mildly active. And if you had neither neutrophilic infiltration nor an ulcer or erosion, you were graded as having inactive disease. And they do this for each biopsy segment along the way, and we tallied these up and looked at it in a number of different ways. And what we found out was that one's mean inflammation across your colonoscopies across time, adjusted at each colonoscopy for the development of advanced neoplasia, gave you a 3 times increased risk for the development of colorectal cancer or high-grade dysplasia. And a lot of the other variables of interest seem to wash out. And this is actually something consistent that you see in the colonoscopic surveillance literature, where age, extent of disease, and duration of disease seem to wash out. And the reason they washed out is once you're, it's seemingly a threshold phenomenon. Once you're at this increased risk, each marginal year or each marginal centimeter of active disease doesn't necessarily increase your risk so much more than anyone else in the cohort under surveillance. And these were all patients under surveillance. Mesalamine use of interest had a point estimate that suggested chemoprevention, but as you can see, the point estimates did not meet statistical significance. And the number of colonoscopies, or really colonoscopy density, not surprisingly, was associated with an increased risk. You look more, you find more, not a surprise at all, and particularly because we tend to look and find more in our patients who have indefinite for dysplasia findings. We bring them back a little bit sooner. Some of them certainly are at risk. And for patients who have polyps that we resect at that time who continue in surveillance, they're at greater risk as well. So these were our findings that nicely got published in Gastro. And what you don't know is that Dr. Gupta, our initial author, who then was on a Doris Duke Fellowship at Mount Sinai from the University of Michigan, was our first author there. So, and she did a great job, and she does primary care in Houston now. So. And so here's the actual publication as well, after we made some adjustments, I should say, from what it is, and I'm not sure, one of those slides should have been deleted. So chemoprevention, right? So we know inflammation causes it, and we came to inflammation in a sort of backwards way because there had been a literature on chemoprevention that had antedated it. And people have long been trying to figure out, well, gosh, these mesalamine agents seem to be working, maybe they seem to be working. What is about them that's chemoprevention? The obvious place to look is their anti-inflammatory activity, and that sort of started to beg the question about, well, no one's bothered to truly demonstrate that inflammation was really this great independent risk factor, which led to Matt Rutter's study and then our Me Too study that we came up with afterwards. So Fernando Valayas, after a number of patients, or rather a number of studies had been published, decided to look at this and do something of a literature review. Can't really call it a meta-analysis, and if Phil were here, I'm sure he would, the fact that meta-analysis would include the summing of case control studies, I'm sure he wouldn't be too pleased. But Fernando did this, and as you can see, there seemed to be this, this nice generalized protection, that the point estimates of chemoprevention seem to all line up toward this, toward chemoprevention when we look at it. But there are a lot of problems with a number of these case control studies. Something of a problem with the small Moody study as well, and folks have really not been too impressed, and others have been overly impressed with the supposed chemopreventive powers of the mesalamine-based agents. And so this has led to a lot of consternation. One of the folks who really has been underwhelmed by this and actually has some negative studies is Chuch Bernstein from up in Manitoba, in Winnipeg. And so he decided to sort of take a step back and say, well, listen, let's ignore these smaller case control studies and let's purely take a look at the larger data-based studies, and the studies that really are more representative of a larger population basis. Now, not all of these are population-based studies, but some are close. And as you can see, there's really not this huge protective effect if you look at these larger studies. Now, is that just a way that he can make his case, or is that true science? I don't know. He presented this at DDW along with a couple of other colleagues. The overall point estimate, as you can see, is just 0.92, favoring chemoprevention in these 5 studies, and I participated in the one with Jonathan Turdeman where we took a look at the larger, some larger databases, the the IMDEX database that a number of our insurers use, and there was no chemo prevention when we looked at 2 years of use, and maybe 2 years was too short a time horizon for a disease that lasts a lifetime. Nevertheless, this is still a big debate. We decided that we would take a look at it in the exact same way that we had looked at inflammation and found that for our patients who were under surveillance, so asking the question for your patients who've had disease for 8 years, who are in a surveillance cohort, what's the effect of mesalamine on their progression? And it turns out almost no matter how you make the cut, looking at advanced neoplasia as an endpoint, the point estimates are less than 1, but they're not so much, so much less than 1. So any use versus some use over time. Yeah.
Is that adjusting for the inflammatory score?
No. We did in the this study came first, even though it got published later. But that this study had a less motivated first author than the Doris Duke Fellow first author, and so later, and there was no adjustment for inflammation over time. Nevertheless, it's not. On its surface, it's just not so hugely chemopreventive, and it actually speaks to a larger point. And so it's really a very informative question, right? So the folks who are on higher dose, and maybe the reason higher dose doesn't work, maybe they're the more inflamed patients over time, and so have you effectively gone at it that way. And so that's why that may be why the greater than 2 grams per day shows actually that point estimate is shifted a little to the right, or a little more toward neutrality, and the number 1 than the any use is. And so average dose, we're able to look at, this is on a per gram increase, just about an 8% reduction, but by no means statistically significant. And then we did the same thing with thiopurines with a different Doris Duke Fellow the previous year, Sierra Matula, and this was before we'd done very much before we'd done our inflammation study as well. And what we found was that the thiopurines were not chemopreventive at all, and I think that speaks probably almost entirely to the notion that we don't randomly select our patients who go on thiopurines. They are by definition, at least at some point in their lives, or their lives with the disease, to have had more inflammation or more of a burden of the disease, usually steroid dependence, and that's why they get put on the 6-MP or azathioprine to begin with. And as you can see, no chemo prevention there. However, we've been scooped or unscooped, or these guys came after us. But Beaujolais and the SESAM cohort took a look at this, and they found really impressive chemo prevention that was statistically significant that they presented at DDW. And I've had this slide just as it is until a year later in DDW 2010, where they had a non-statistically significant finding for thiopurine use. And they haven't gotten either one into the peer-reviewed literature, which just tells you that it's not just me out there who's slow to move. So I don't know where they stand on this, and usually, or I often, not usually, but I often do get asked to review these kinds of things, and I'm yet to see this one in the literature, and I've not been asked to review it yet either. However, the Dutch group with Van Schaik and colleagues and a group out of Holland did a health services investigation of Dutch data, and they were able to do some of the proper exclusions. They had an enormous number of patients that they were able to follow through their tertiary centers, and there had been 28 cases of advanced neoplasia that had been found. So I want you, this is an important lesson here. All of Holland, over those 9 years, smaller than Mount Sinai. So very odd. So if I get IBD, I'm moving to Holland, because bad things don't seem to happen there, at least as frequently. And 14 of those cases were colorectal cancer. There was some overlap. Some patients had both. That's why it's there. And about an eighth of them had been exposed to thiopurines for 3 or more years during the time that they were able to investigate. They defined exposure as any continuous 6 months or more of use. And they found really impressive chemoprevention. And even though this says abstract number 185, I should have updated this slide, and I apologize. This was actually published in Gut, I think in the July or August issue of this past year. And so they've demonstrated that contrary to what we found, that thiopurines are in fact chemopreventive. And so I still think that this is an open question. I think it gives us further ammunition, for lack of a better word, to suggest to our patients who are on thiopurines with ulcerative colitis and doing well that they continue those medications and not get themselves into trouble either from a cancer or a colitis flare perspective. So URSO and PSC patients, this was the randomized cohort study that looked at it. Now the initial endpoint for this was not the development of neoplasia. This was an endpoint that they glommed onto after a publication had demonstrated decreased neoplasia in a case control fashion from the Seattle group. And so this is Daryl Pardee in the Mayo Clinic's study looking at URSO, and it certainly looked as though that URSO was in fact chemopreventive. And this has sort of been dogma to some extent for some time. But then Keith Lindner and that group decided, well, if a little URSO doesn't do enough for preventing transplant or mortality due to your liver disease, maybe we're just not giving enough. So they tried it at high dose, and they found out in a previous publication that I don't have a slide for that, in fact, there was more death and more transplantation at the higher dose. That's at the 28 to 30 mg per kg dosing per day. And it turns out that high dose also is actually pro-neoplastic as opposed to chemopreventive. And so you can see that those URSO patients were much more likely to develop cancer. Other little tidbits of information from that study, which was just published, I believe, last month, maybe this month, in the Red Journal, was that mesalamine was not chemopreventive in this study. And that, again, duration and extent for this group that's already at high risk, no matter which arm they were subjected to, didn't seem to matter either. So, that's an update on where we stand, I think, in the chemo prevention literature. I didn't show you the folic acid data, but it's never been statistically significant, though point estimates have always suggested a chemopreventive effect. So I do tend to put my patients on a milligram or 600, 800 micrograms of folic acid a day. So what about, what should we be doing with our patients with low-grade dysplasia? So it turns out that, that there's variability in what's out there in the literature, but at least what had been published to tell us what happens if you resect and or have had low-grade dysplasia, and that was the maximum of what you had found at your surveillance or your colonoscopy, whether it was for surveillance or not prior to a colectomy, albeit in small studies, but seems to be a good amount of uniformity here, was that you harbored about a 1 in 5 shot of already harboring a colorectal cancer at that time. So that was pretty impressive. And then when Chuck Bernstein had first published this in '94, it actually it was in the Lancet and came with a very, very provocative title, which was, "Are we telling our patients the truth?" And really, prior to '94, no one operated for low-grade dysplasia. And then the pendulum started to swing this way when these findings came out in the middle of the last decade. And now maybe not so certain what the level of agreement is between a surveillance finding and a colectomy finding when it's found. But it seemed to be that this was a pretty impressive, albeit small studies or small numbers, risks of progression for colectomy. So what happens if you don't have surgery and you just follow along? Well, there seems to be a split in the literature, and this slide is by no means comprehensive. But what you can see is that there's really a good amount of variability with a number of studies showing fairly impressive rate of progression over time, certainly different than that 0.5 to 1.0% that we saw early on just in general for risk. And in fact, we're talking about 25 to 54% in that upper bracket up there for progression from low-grade dysplasia to something more ominous. But then there have also been some groups that have found very, very low rates of progression. Beffert's found almost none. In fact, you could argue that 2% at 10 years is far less than the 0.5 to 1% of doing nothing. And I'm not sure what was going on with his group and how that could be. Are there differences in what our pathologists interpret as low-grade dysplasia? I've always clinged to that kind of concept, though I don't really know. But I can tell you, if you're at Mayo or you're Mount Sinai or you're at St. Mark's in the UK and you have low-grade dysplasia, I think you need to think really hard about not recommending a colectomy in those patients. When we looked at this, one of the things that, the slim pickings and the easy solution I was looking for was trying to find out, well, if we just separate multifocal from unifocal, then of course we'll have a branch point and we'll figure out who the patients who are really likely to progress are versus those who just have maybe a moderate increase of rate of progression over continued surveillance. But it didn't turn out that way, as you can see, and the curves are nearly superimposed between unifocal and multifocal low-grade dysplasia. And none of the other variables seem to matter. And what was, I think, even more scary in this publication that we had was that many patients continued to be followed for low-grade dysplasia over time, did not progress through high-grade dysplasia prior to the development of node-positive colorectal cancer. And you can see the top 2 patients on this timeline, that's what happened to them. And in fact, not only did they not progress through high-grade dysplasia, but in fact they had a completely normal colonoscopy prior to having their colorectal cancer discovered, going to surgery and being found to be node positive. So you're rolling the dice quite seriously if you're. Yep.
In this group, or that study, did you look at smokers versus non-smokers? Was that sorted out?
We didn't, and we were dependent in this study, and actually in all of the studies that you've seen on dysplasia from Mount Sinai, we're dependent on outpatient records and charts of mostly private practitioners. Not that that matters, just gastroenterologists, I should say, whose dedication to filling in certain information about smoking history, family history, and other variables that we would like to consider in the larger world. They're just not there, or weren't reliably enough there for us to want to include them in our analyses. So as if that weren't scary enough, right, that you might have a 1 in 5 chance of already harboring a cancer, that if you proceed with colonoscopy, maybe 50-50 in 5 years of developing something you would certainly want to have surgery for, including node-positive cancers, without progressing through high-grade dysplasia. There's also this phenomenon that our pathologists have figured out, and sadly I couldn't find, in my multiple slides, I couldn't find nice pictures of what this is, but it's something that they have termed low-grade tubular glandular adenocarcinoma. And what it is these are just dysplastic-looking glands, not particularly cancerous glands, but behaving like cancer, well below the basement membrane and sometimes into the muscularis mucosa. And it turns out that these constitute a fair number of the cancers we see. So it's really just low-grade dysplasia on the surface. It's low-grade dysplasia through much of the mucosa, but in fact, it has some behavior like a cancer. And bizarrely, there's only a minimal desmoplastic reaction, minimal intraluminal necrosis, and really only looks like low-grade dysplasia, even where it's not sitting up on the epithelial surface. And I sadly don't have pictures for you. Frequently associated with IBD, it's not much out there in the sporadic colorectal cancer literature, and may count for almost a tenth, or at least 11%, of the IBD-associated cancers we've seen at Mount Sinai. And many patients have multifocality of this, and so it's very, sort of very concerning that sometimes when you just see low-grade dysplasia on the surface, really bad things might be happening below. So what about polyploid low-grade dysplasia? And this is certainly much more frequently than this sort of flat or undiscovered, non-targeted biopsy low-grade dysplasia. There's no clear-cut distinction between what is a DALM and what is an adenoma. DALM, or dysplasia-associated lesion in mass, that term came from a study by Blackstone and colleagues at the University of Chicago. And these were patients who were brought in because they had these mass-like lesions that were noted at either barium study or a colonoscopy prior to their referral down to the University of Chicago. And many of these mass lesions probably were cancers, but were biopsied, and many of them could have been these low-grade tubular glandular adenocarcinomas for all we know. But these were masses that no one would think of resecting with snare polypectomy. But when you find a little polyp that looks like an adenoma, well, maybe that really is more like an adenoma. And how big is too big, is really in the eye of the beholder. I brought in the rabbi and the pope earlier when I was struggling, and now I have to bring in Justice Stewart's definition of pornography, which was, I know it when I see it. And that's true for the distinction between an adenoma and a DALM-like lesion, right? And my desire or ability to yank out a polyp with snare cautery might be very different from any of yours. And we might hesitate at different points and send a patient to surgery for different reasons. I don't think any of us would have troubles wanting to resect lesions on the left, the one on the left or the one on the right here. We could easily get our snares around that and remove them. And there were these paired papers in 1999 by the Brigham and Women's Group and the Mount Sinai Group before I got there that demonstrated that this was okay to do. And I'll show you that literature in a bit. But and maybe that should have preceded this, but I think the bottom line is you have to send a patient to colectomy if there's coexistent flat dysplasia or adenocarcinoma. If you can't remove it, that's sort of the last row there, and then if you have any of those things in the middle, which is anything that isn't a small or discrete lesion. So if you don't have something that's amenable to polypectomy because it's a small, and we'll leave that term purposefully vague and discrete, you shouldn't mess with it. Those patients should go to surgery. Small, discrete, amenable to a polypectomy. You can take it out and bring them back. And it turns out if you do that, you actually have very, very low rates of developing cancer later on. And it really, it's been very reassuring that the literature has borne this out. So it was initially proposed in '99, and you can see that they had very low rates that were there. And then it seemed to progress. Not much else happened. And you can see that those patients who went on for colectomy, based on Bernstein's summary review in that Lancet article in '94, had a pretty high rate of cancer. And then in Matt Rutter's group from taking a look at the St. Mark's database, there was really almost a 1 in 3 chance of already harboring a malignancy. So we do take polyps out, we do take small discrete dysplastic lesions out and bring these patients back for subsequent colonoscopies in 3 to 6 months, and sometime after, if we continue to clear the colon, we continue to relax it. And in this publication, which we've had EPUB'd, we were looking at something that was a little different, but it I think very nicely demonstrated that there's a difference between having raised dysplastic lesions and flat, and by flat we mean identified through a non-targeted biopsy. And so this is going to come out in GI endoscopy at some point. It's already been e-published, but we were looking at something different, which was whether there's a difference between left-sided and right-sided things. Peter's familiar with that article, and here it was in fact, and it turns out that proximal behaved a little bit different from distal. So, which really brings us to this whole idea that when we're doing surveillance colonoscopy, we think it works. We might add on some medicines to make it more chemopreventive. But what about the endoscopy itself? Are we doing what is, I think, has always been the goal of surveillance colonoscopy and IBD, which is really to make it look and behave a lot more like we do with sporadic polyps and sporadic colorectal cancer, where you go in and you either completely clear the colon or you send that patient to surgery. And we're starting to get there. And one of the things that's maybe helping us start to get there are these adjunctive endoscopic techniques. And so, we ask this question: Do these work? Is the old way of performing surveillance, still worthwhile, or should we make this transition to a world of chromo endoscopy? And so chromo is very helpful. And so lesions that you wouldn't otherwise see in white light, it has been somewhat demonstrated, you can find by applying either diluted methylene blue or diluted indigo carmine through the scope. And this used to be terrifically complicated before we had that foot pedal wash, right? So we used to have to sort of thread out some sort of spray dye catheter that would project the blue liquid, in a nice 120-degree cone, and it was really fantastic until you were moving the threading it in and out and getting all sorts of laundry coated with these blue dyes that didn't come out in clothes and patients' skin, and it was a real mess. But now we just add the dye spray right into the big bit of water that's there, and now I'm going to maybe add some peppermint oil to it too. I've found from Peter that might be very helpful. So we can find lesions perhaps a little bit better. That scarred down colon on the left, we've all seen that. See it a couple times a scope session in our older colitis patients. And Kieslich would argue that if you just applied the spray dye, you would find out that you had that messy-looking lesion there, which, by the way, that to me is a dome. Some of you might want to resect that piecemeal or otherwise. That's just too big for me to want to monkey around with. Jerry Way, of course, he would take care of it. So there have been a number of prospective studies that have compared detection rates of chromoendoscopy to white light, and they've all demonstrated anywhere from a 1.5-fold increase at our institution. Jim Marion led that study, to as high as almost a 5-fold increased rate of lesion detection, whether you used indigo carmine or methylene blue. Ours were using standard scopes, not using high-def scopes or magnifying scopes. Maybe that's why we're a little bit lower. It's unclear. And here's from our literature, and we're sort of running out of time. But does detecting more dysplasia really matter? How much are we missing? And so this thing that really has not seen the light of day of publication yet, again, not a very motivated first author. We took a look at our debate database. We had 1,183 patients who were who'd undergone a surveillance examination with extensive disease. We counted the number of cases with colorectal cancer without prior dysplasia of any kind. So to go from that no dysplasia state with non-targeted biopsies to a state of full-on colorectal cancer was 0.085%. We had one such patient. Sadly, that number is now 2. Since we've done that study in a very ugly case I'll tell all of you about in private. But the bottom line here is that the old system really wasn't so bad. Peter, with one of your fellows here, did a really amazing study. I thought that, I think forces us to think about what this adjunctive benefit might be as well. So there's reason to think that the old system wasn't so bad, even though the new system has a greater rate of detection. But the larger issue that's there is that, and I had to do that with the modeling with 2 L's there, mostly because it came out with the underline red. But the modeling here highlights the possibility that the currently understood clinical implications of flat low-grade dysplasia are unlikely to be transferable to dysplasia found using more sensitive techniques. So we're going to change the natural history just by using a different technique. And this has been discovered and described in a large number of different disease states. And I think, Peter may argue, and the other authors may argue, and many readers may argue, I think that this was the most important sentence and the most important finding of this study, which showed that to find dysplasia in a non-targeted fashion, you have to have a pretty big field, bigger field of dysplasia than these small 2 millimeter, 3 millimeter polyps that we're talking about removing as adenomas. So this actually was described in the mid-1980s and was called the Will Rogers phenomenon by my clinical epidemiology mentor, Alvin Feinstein, who is the creator of the word comorbidity, by the way, among other things. And Alvin quoted Will Rogers, who said that when all the Okies left Oklahoma and moved to California, this is during the Great Depression, they raised the average intelligence level of both states. And so what we've seen in a number of different states is this thing that's called stage migration. And so if you have a better sieve, if you have a better way of weeding out those diseased from not diseased, you can start to move patients up each stage, demonstrate that each stage does better than it had before without changing overall survival, without having any kind of treatment change. Same number of people are going to run into trouble. And so the prognosis at every level in the colitis dysplasia carcinoma sequence is going to change with chromo, and actually has changed. So everything is less dangerous, seemingly, than it was before. At least that's a hypothesis. It remains untested. I think Dr. Higgins would agree with me. I'm not sure, but we'll talk about that later. And so, what we really need in these world of adjunctive techniques, and we could have used before we all got carried away with what we do, is we need longitudinal studies that are going to look not just at dysplasia yield, but whether or not you develop cancer. The real endpoint that we care about here is cancer morbidity and mortality. Cost will be a big driver of whether or not these techniques are appropriate to be used and are ready for prime time. And I think what we'll eventually do is eventually we will look more and more like sporadic colorectal cancer dysplasia surveillance, in that it's going to be spread out over time. We'll have longer intervals between cases, and we won't have any uptick in morbidity or mortality in so doing, and that should drive the cost down over time. So it is something to look forward to, and I think that that's the promise of these adjunctive techniques. So, and these are my last set of slides, and I know we're getting late here. Are we decreasing colorectal cancer morbidity and mortality in IBD? Well, that left curve suggested that it was all gloom and doom, that Jane Eden meta-analysis that I showed you before. In our mesalamine study, we were among other things, we were able to demonstrate that that it turns out that if you have no dysplasia on a surveillance examination and you start your stopwatch then, that your rate of progression is really, really quite low. That very first examination is very helpful at weeding out who will or won't progress over time. It doesn't mean you need to abandon it, but it turns out that a lot of the gloom and doom that we expected. And so that blue curve on the right, just compare the shape and the size of it and the slope to what we saw in the Eden meta-analysis. So I believe this is really great indirect evidence that surveillance is very, very helpful. And it turns out that that our risks for developing colorectal cancer aren't that great anymore. So compared to the general population, which granted people are still developing colorectal cancer in the general population, but if you take that in the denominator and you put in the numerator colitis-related colorectal cancer, some more modern studies are really demonstrating that risk isn't so increased, at least in the two Scandinavian populations that I have here, Olmsted, Minnesota, and Copenhagen. I got one smile, but thanks. So Winston Churchill very famously said about the world politics that democracy is the worst form of government except for all of the others. And I would argue that surveillance colonoscopy, as we practice it now, and our current practices are really the worst ways to prevent cancer in IBD except for all the others. I think we're doing a good job. And I used to sort of badmouth the system, and I used to think we had to, run roughshod over it and come up with a better solution. It turns out that our old solution actually was pretty good. It was pretty good, and it's a very nice place for us to be right now, where I think we're doing a good job. Another great thinker from the 20th century, James Brown, had a few things to say about this. He reminded us that most of our patients who are enrolled in surveillance are actually feeling okay. And this becomes a very challenging issue when you pick up dysplasia on someone who's feeling good and convincing them they have to have their whole colon taken out after struggling with the disease. I have 2 ongoing conversations with people who are refusing to have their colons removed. This is very, very tough. It's important that we think about extending out surveillance and not bringing these patients back every year ad infinitum for a negative colonoscopy. The recommendations are actually for every 1 to 2 years for our non-PSC patients. I have started to send my patients out to every 2 years. Hopefully I won't harm anyone in doing it. I think eventually we will do them even less frequently than that. And it's important that we think of our patients as our patients and not so much as the folks who are helping our kids go to excellent colleges and wear cool shoes. Also from the same song, we want to keep our patients alive. We have to keep remembering that it's not about preventing colectomies, it's about preventing cancer and cancer death. And finally, if we can, we'd like to avoid unnecessary stomas, which really can be tough for patients to handle. And finally, I just want to thank my collaborators on this. Steve Itzkowitz, who's been this wonderful mentor and friend through the years, Noam Harpaz, our pathologist, and then 4 people who have taken a year either as Doris Duke Fellows or as just plain old med students taking a year to do research. Not one of them, Steve and I always point out, not one of them, they were working for both of us, has gone into IBD or GI. So we're doing something wrong. But I can tell you that 3 of the 4 got engaged during their year with us. So, not to people we introduced them to, of course. But, and that's it. I'm sorry I ran over time, and thanks for your patience. I appreciate it.